No, thank you again. We're going to talk about concomitant common femoral iliac disease, and should I treat both hybrid or endo? I'm now worried to kind of talk about endo versus open past the debate here, but we'll take it from there. Here are my disclosures. So really, I'm going to sit down and really kind of define the problem here. I mean, we all know it's almost impossible to define just isolated common femoral disease or isolated iliac or isolated SFA. It's kind of one long, elongated problem, and you're trying to figure out where should I start, where should I end, what do I think is sufficient and not. We'll talk a little about open, endo, and hybrid, which I think is really taking off, and then look at some evidence and show you kind of my algorithm for this. So. Obviously, as was discussed by the previous speakers, endarterectomy still remains a very viable option, particularly for the management of common femoral artery disease. The problem is, what do you do with the inflow segment from the iliac? You could consider endovascular options such as stenting, atherectomy, as we're seeing currently now by Dr. Schmidt, live with or without PTA. And then, of course, the hybrid approach is open reconstruction with either retrograde stenting or antegrade stenting, all done at the same setting, which could make things a little bit more complicated, but at least you can come up with a result that hopefully is going to be durable. And clearly, multi-level endovascular options such as iliac SFA, et cetera, et cetera. So, what's the evidence? I mean, there really isn't that much. I was evaluated in doing a literature review, pure endovascular versus a hybrid approach, looking at iliofemoral disease, and even this was a randomized controlled trial that was performed in the past. I mean, there's a variety of systematic studies, and I'll go through a couple of these just to show, even with some recent RCTs, demonstrating, comparable short-term outcomes, whether it was with common femoral artery stenting, in addition to SFA stenting or iliac stenting versus open repair. This was one that came up actually as well not so long ago, a systematic review and meta-analysis, which I'll show you here, moving forward with the management of patients with endarterectomy and femoral artery disease. You can see here to the screen left where this looks at a forest plot for technical success, and to the screen right looking at symptom improvement for open femoral intervention versus endovascular. And you can see here that it was favorable for open reconstruction as compared to endovascular, that was statistically significant with regards to technical success, more so than endo. Similarly, to the screen right, you can see a benefit statistically significant for symptom improvement with open endarterectomy as compared to endovascular reconstruction of the femoral system. Furthermore, over here, what's important from a limb perspective, however, forest plot for limb salvage versus amputation, similar between two. In addition, looking at short-term mortality and long-term mortality, again, no statistically significant difference between considerations for an endovascular approach, the femoral artery versus an open repair. So what is it we would do? It seems like the data is somewhat conflicting. This was done actually from my colleagues in Ann Arbor in Michigan, again looking at hybrid versus endovascular, again reconstruction of the iliofemoral segment. This was quite nice to be able to see it should be all done within the same setting. They used a mole endarterectomy ring to help do a retrograde iliofemoral reconstruction, again from an open approach in the common femoral artery, which was all relatively similar. We know that there is an increase in hybrid approaches, again with open femoral artery, common femoral artery repair, and retrograde either iliac stenting or retrograde remote endarterectomy with a mole endarterectomy ring. Piazza here, again, just some high-level data showing that primary patency rates after a hybrid repair were compared favorably to open aorta iliac reconstruction in what was considered complicated task C and D lesions, but this was not statistically significant. Furthermore, Nelson and colleagues similarly looked at a similar primary assisted patency when treating extensive iliofemoral disease compared to open common femoral artery. So what are the outcomes? And hybrid, good technical success, perioperative morbidity is good, durable midterm patency, endovascular only clearly better perioperative morbidity, but we always tend to worry about long-term durability and the need to re-intervene. And open surgery, of course, we know the gold standard, if you will, for durable patency, but highest surgical risk in these patients. Looking at some of this as well, again, some of these looking at multi-level intervention versus iliac only. Similarly, you can see not statistically significant for management of multi-level disease versus isolated disease. Primary patency, similarly, was not different for treating only iliac versus doing iliac, common femoral, and SFA at the same time. So there was no real difference in those as well. Limb salvage rate was similar between treating multi-level aorta iliac, common femoral and SFA versus iliac only. So if you could do it all at the same time, why not? This is hot off the press from Catheterization and Cardiovascular Interventions here in August of 2025. Very interesting paper from Russia looking at endovascular versus hybrid repair in a randomized trial. And I'll kind of show it with you. Interestingly, here's the inclusion. Had to have type C-D lesions. As you can see there, iliac segment and CFA over 70%, Rutherford 3 to 5, and then they had to have essentially non-obstructive infrainguinal disease, which I found very, very interesting that they were able to find patients to even enroll in this particular trial. You can see here 62 patients were randomized to endovascular therapy versus hybrid repair. Endovascular therapy was basically treatment with a nitinol superistent from the common femoral artery proximally to the iliac, all the way, versus a hybrid repair, which was an open femoral end arterectomy with retrograde iliac stenting as well. And length of stay was better in the endovascular group, but there were no mortalities or major cardiovascular events in either group with 30 days, and I'll show you here some more of the data. Interestingly, primary patency was better in the open group, the hybrid group, in the short term, as compared to endovascular therapy, but looking at the secondary patency rates, these were similar between both groups. So the predictors were with the type of reconstruction, so favorable for open repair, hybrid repair, so femoral end arterectomy with retrograde stenting, as compared to just endovascular reconstruction. And of course, what the indication was. So patients that were having it done for intermittent claudication had better patency as compared to those with more diffuse disease or CLTI. So what do you need to worry about? Lesion characteristics, again, does it spill over into the profunda? In my practice, those tend to go for endarterectomy. How complex it is. It may favor hybrid or even open reconstruction, although we've demonstrated earlier that there are new techniques to be able to manage these in an endovascular approach. And of course, patient factors, can they tolerate this or not? So my algorithm, multidisciplinary review, look at imaging, see where you're at. If the CFA is involved in the bifurcation of profunda, consider endarterectomy. I mean, this is what it is. I know, just as a surgeon, to kind of show you the type of lesions that we see. This is the endarterectomy. In order to remove that, this is what it should look like when you're done. Sometimes it's hard to be able to manage it in the endovascular approach or with stenting because of the significant bulky calcium. And this is a reconstructed femoral endart onto the profunda with a proximal patch. If the CFA is focal and suitable, consider endovascular. High surgical risk, favor endovascular. And then, of course, ensure you have a plan for something more durable down the time, if at all possible. Thank you so much for your attention.